Question 1. A client with a new tracheostomy tube is experiencing frequent coughing and secretion production. Which intervention should the nurse prioritize to maintain airway patency? A. Administer a prescribed antitussive medication to suppress the cough reflex. B. Increase the frequency of tracheostomy cuff deflation to promote expectoration. C. Perform tracheostomy suctioning as needed based on assessment findings. D. Encourage the client to deep breathe and cough forcefully every hour. Answer: C. Perform tracheostomy suctioning as needed based on assessment findings. This question tests the nurse's priority action for a client with a new tracheostomy experiencing increased secretions. The key concept is maintaining a patent airway, and the most direct and effective intervention for a client with a tracheostomy and secretions is suctioning. While deep breathing and coughing are generally helpful, a new tracheostomy often bypasses upper airway clearance mechanisms, making direct suctioning essential to remove secretions that the client cannot effectively clear. For example, if the client has gurgling breath sounds or increased respiratory rate, suctioning would be immediately indicated. Always remember that direct airway management is paramount for clients with tracheostomies. Question 2. A nurse is assessing a client with chronic obstructive pulmonary disease, COPD, who reports worsening dyspnea. The assessment reveals diminished breath sounds, a barrel chest, and clubbing of the fingers. Which finding would most likely indicate an acute exacerbation requiring immediate intervention? A. Barrel chest. B. Clubbing of fingers. C. Diminished breath sounds. D. Use of accessory muscles for breathing. Answer: D. Use of accessory muscles for breathing. This question focuses on identifying acute respiratory distress in a client with chronic COPD. Keywords like worsening dyspnea and acute exacerbation point to a sudden change in status. A barrel chest, clubbing of fingers, and chronically diminished breath sounds are long-term manifestations of COPD and do not indicate an acute change. However, the new or increased use of accessory muscles for breathing signals that the client is working harder to breathe and is in respiratory distress, demanding immediate nursing intervention. For instance, observing sternocleidomastoid or intercostal muscle retraction indicates an acute exacerbation. When assessing chronic conditions, always look for new or worsening signs that signify an acute problem. Question 3. A client is admitted with suspected pulmonary embolism, PE. Which arterial blood gas, ABG, finding would the nurse initially expect in the early stages of a PE? A. Respiratory acidosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: C. Respiratory alkalosis. This question tests understanding of the initial physiological response to a pulmonary embolism. The key clue is initially expect in the early stages. A pulmonary embolism causes hypoxemia and anxiety, which leads to hyperventilation as the body tries to compensate. Hyperventilation blows off more carbon dioxide, leading to a decrease in PaCO2 and a rise in pH, resulting in respiratory alkalosis. For example, a client might present with a pH of 7.48 and PaCO2 of 30 mm of mercury. Remember that the body's first instinct when sensing inadequate oxygen is often to breathe faster and deeper, leading to an initial respiratory alkalosis. Question 4. A client is receiving oxygen therapy via nasal cannula at 5 liters per minute. The nurse notes the client's pulse oximetry reading is 88%. The client is alert and cooperative. What is the most appropriate initial nursing action? A. Increase the oxygen flow rate to 8 liters per minute. B. Encourage the client to cough and deep breathe. C. Recheck the pulse oximetry reading on a different finger or site. D. Switch the client to a non-rebreather mask. Answer: D. Switch the client to a non-rebreather mask. This question assesses the appropriate response to acute hypoxemia despite current oxygen therapy. The pulse oximetry reading of 88% on 5 liters per minute nasal cannula indicates that the current oxygen delivery is insufficient for the client's needs. A non-rebreather mask delivers a higher concentration of oxygen, up to 90 to 100%, and is indicated for clients requiring a greater oxygen supply to improve saturation rapidly. While deep breathing and coughing are beneficial for lung expansion, they will not acutely increase oxygen saturation to the necessary level. For instance, if a client's SpO2 drops below 90% on a nasal cannula, escalating to a non-rebreather mask is a critical next step. When oxygen saturation remains low despite current therapy, always consider escalating the oxygen delivery method to a higher flow system. Question 5. A nurse is caring for a client with a chest tube inserted for a pneumothorax. Which finding in the chest tube drainage system requires immediate intervention? A. Continuous bubbling in the water seal chamber. B. Fluctuation, tidling, in the water seal chamber. C. Serosanguineous drainage of 75 milliliters in the past hour. D. Suction control chamber bubbling gently. Answer: A. Continuous bubbling in the water seal chamber. This question evaluates the nurse's ability to identify a critical complication related to chest tube management. Continuous bubbling in the water seal chamber indicates a persistent air leak in the system, which means air is still escaping from the lung or there is a leak within the tubing itself. This finding is abnormal and prevents the lung from fully re-expanding, requiring immediate assessment to locate and correct the source of the leak. Tidling is expected, and a moderate amount of serosanguineous drainage is common post-procedure, as is gentle bubbling in the suction control. For example, if a client's chest tube shows constant, vigorous bubbling, the nurse should systematically check connections and the insertion site for air leaks. Always remember that constant bubbling in the water seal chamber signals an air leak that needs prompt attention. Question 6. A client with asthma is prescribed a daily inhaled corticosteroid and a short-acting beta agonist, SABA, for rescue. The client reports needing to use the SABA 3 to 4 times a week. What does this indicate to the nurse? A. The client's asthma is well controlled. B. The client is overusing the SABA due to anxiety. C. The client's inhaled corticosteroid dose may need adjustment. D. The client should switch to a long-acting beta agonist, LABA, for daily control. Answer: C. The client's inhaled corticosteroid dose may need adjustment. This question assesses understanding of asthma control and medication management. Regular use of a short-acting beta agonist, SABA, more than twice a week indicates poor asthma control, as SABAs are for quick relief of symptoms, not for daily management. The primary long-term controller medication for asthma is an inhaled corticosteroid, and increased SABA use suggests the current anti-inflammatory therapy is insufficient. For example, if a client reports using their albuterol inhaler several times a week, it signals that their underlying airway inflammation is not adequately managed by their daily maintenance medication. When SABA use increases, it's a clear sign to reassess the effectiveness of the client's controller medication. Question 7. A nurse is educating a client recently diagnosed with tuberculosis, TB, about medication adherence. The client expresses concern about the long duration of treatment. What is the most important teaching point regarding medication adherence for TB? A. Missing doses can lead to uncomfortable side effects. B. Completing the full course of treatment prevents drug-resistant TB. C. Adherence will help the client feel better sooner. D. Family members will also need prophylactic treatment. Answer: B. Completing the full course of treatment prevents drug-resistant TB. This question evaluates the most critical aspect of tuberculosis, TB, medication adherence. While feeling better sooner and avoiding side effects are important, the most significant public health and individual health consequence of non-adherence to TB medication is the development of drug-resistant strains. This makes treatment much more difficult and extends the duration, posing a risk to the client and the community. For instance, if a client stops taking their medication early because they feel better, the remaining bacteria may mutate and become resistant to the drugs, making subsequent treatment much harder. Always emphasize that completing the entire prescribed course is vital to eradicate the infection completely and prevent the emergence of drug resistance. Question 8. A nurse is preparing to suction a client with a tracheostomy. Which action is most important to prevent complications during the procedure? A. Administering a bronchodilator prior to suctioning. B. Hyperoxygenating the client before and after suctioning. C. Applying continuous suction while inserting the catheter. D. Limiting suction passes to a maximum of 4. Answer: B. Hyperoxygenating the client before and after suctioning. This question focuses on the crucial safety measure during tracheostomy suctioning. The most important action to prevent complications like hypoxemia and cardiac dysrhythmias is to hyperoxygenate the client, preoxygenate, before and after the procedure. Suctioning removes oxygen along with secretions, so providing extra oxygen helps maintain oxygen saturation levels throughout the process. For example, delivering 100% oxygen for 30 to 60 seconds before inserting the catheter significantly reduces the risk of oxygen desaturation. Always prioritize pre- and post-oxygenation to minimize the risk of hypoxemia during suctioning. Question 9. A client is admitted with acute respiratory distress syndrome, ARDS. The nurse understands that ARDS is characterized by which primary physiological alteration? A. Progressive pulmonary hypertension. B. Widespread collapse of the alveoli. C. Non-cardiogenic pulmonary edema. D. Chronic airway inflammation and bronchospasm. Answer: C. Non-cardiogenic pulmonary edema. This question tests the foundational understanding of the pathophysiology of acute respiratory distress syndrome, ARDS. ARDS is primarily characterized by severe, non-cardiogenic pulmonary edema, meaning the fluid in the lungs is not due to heart failure. This edema results from increased permeability of the alveolar capillary membrane, leading to fluid leaking into the interstitial and alveolar spaces, impairing gas exchange. For example, a client with ARDS will have severe hypoxemia despite high levels of supplemental oxygen because the fluid prevents oxygen from reaching the bloodstream. The hallmark of ARDS is the leakage of fluid into the alveoli, causing severe gas exchange impairment. Question 10. A client with pneumonia is experiencing pleuritic chest pain. Which intervention would be most effective in managing this type of pain? A. Administering a cough suppressant. B. Encouraging shallow breathing to avoid pain. C. Administering a prescribed nonsteroidal anti-inflammatory drug, NSAID. D. Applying a warm compress to the chest. Answer: C. Administering a prescribed nonsteroidal anti-inflammatory drug, NSAID. This question addresses pain management specifically for pleuritic chest pain associated with pneumonia. Pleuritic pain is sharp, stabbing pain that worsens with deep breathing, coughing, or movement, and it is caused by inflammation of the pleura. NSAIDs are effective in reducing inflammation and pain, making them the most effective pharmacological intervention for this type of pain. Cough suppressants do not address the inflammatory pain, shallow breathing can lead to atelectasis, and warm compresses may provide minimal relief. For example, a client with pleuritic pain may find significant relief after receiving ibuprofen, allowing them to breathe more comfortably. Remember that NSAIDs target the inflammation causing pleuritic pain directly. Question 11. A nurse is conducting a respiratory assessment on a client. Which finding would be most indicative of severe airflow limitation? A. Inspiratory wheezes. B. Fine crackles. C. Stridor. D. Rhonchi. Answer: C. Stridor. This question assesses the ability to identify a severe airway compromise based on auscultation findings. Stridor is a high-pitched, harsh, inspiratory sound caused by turbulent airflow through a severely narrowed upper airway, such as the larynx or trachea. This is a critical finding indicating a life-threatening obstruction and requires immediate intervention. Inspiratory wheezes indicate lower airway narrowing, while fine crackles suggest fluid in the alveoli, and rhonchi indicate secretions in larger airways, none of which signify an immediate upper airway emergency like stridor. For example, a child with epiglottitis might present with stridor, indicating a medical emergency. Always remember that stridor is a sign of a severe upper airway obstruction and warrants urgent attention. Question 12. A client is scheduled for a bronchoscopy. Which pre-procedure instruction is most critical for the nurse to provide? A. NPO status for 6 to 8 hours prior to the procedure. B. The procedure will take approximately 2 hours. C. They will be fully awake and able to communicate during the procedure. D. There will be a temporary hoarseness after the procedure. Answer: A. NPO status for 6 to 8 hours prior to the procedure. This question focuses on the most critical safety instruction before a bronchoscopy. The key concern during a bronchoscopy is the risk of aspiration, as the procedure involves passing an endoscope into the airway and often uses local anesthetics that numb the gag reflex. Maintaining NPO, nothing by mouth, status for 6 to 8 hours prior is essential to ensure the stomach is empty, thereby minimizing the risk of aspiration of gastric contents. While temporary hoarseness can occur, and the client will likely be sedated, the NPO status directly addresses a major safety risk. For example, if a client eats before the procedure, they are at a much higher risk of aspirating food particles. Always prioritize NPO status before any procedure that involves manipulating the airway or suppresses the gag reflex. Question 13. A client with cystic fibrosis, CF, is admitted with increased respiratory symptoms. The nurse understands that a priority intervention for this client is aimed at which primary issue? A. Reducing inflammation of the pancreatic ducts. B. Improving nutrient absorption in the small intestine. C. Mobilizing and clearing thick, tenacious secretions. D. Preventing bone demineralization. Answer: C. Mobilizing and clearing thick, tenacious secretions. This question targets the primary respiratory challenge in cystic fibrosis, CF. The core pathophysiological problem in CF is the production of abnormally thick, sticky mucus that obstructs airways, making it difficult to breathe and leading to chronic infections and inflammation. Therefore, a priority nursing intervention is to mobilize and clear these tenacious secretions to maintain airway patency and reduce the risk of infection. While CF affects other systems, respiratory complications are the leading cause of morbidity and mortality. For instance, interventions like chest physiotherapy, bronchodilators, and mucolytics are aimed at helping clients clear these secretions. Remember that in CF, the battle against thick mucus in the lungs is constant and crucial. Question 14. A client is receiving positive end expiratory pressure, PEEP, ventilation. The nurse should closely monitor for which potential complication associated with PEEP? A. Hyperglycemia. B. Hypotension. C. Peripheral edema. D. Increased intracranial pressure, ICP. Answer: B. Hypotension. This question assesses knowledge of potential complications of positive end expiratory pressure, PEEP. PEEP applies positive pressure to the airways at the end of expiration, which can increase intrathoracic pressure. This increased pressure can compress the vena cava, reducing venous return to the heart, which in turn decreases cardiac output and can lead to hypotension. While increased ICP is a concern, hypotension due to decreased cardiac output is a more direct and common systemic complication of PEEP. For example, if a client on high PEEP exhibits a sudden drop in blood pressure, the nurse should suspect decreased venous return. Always monitor for signs of decreased cardiac output and hypotension in clients receiving PEEP. Question 15. A client with a severe exacerbation of asthma presents with absent breath sounds and minimal wheezing. The nurse recognizes this as an ominous sign indicating what? A. The client is improving due to bronchodilation. B. Airway obstruction has become severe, leading to little air movement. C. The client is hyperventilating, causing decreased audible sounds. D. The client is experiencing a silent myocardial infarction. Answer: B. Airway obstruction has become severe, leading to little air movement. This question challenges the nurse to interpret a critical and potentially life-threatening assessment finding in asthma. In a severe asthma exacerbation, a sudden decrease or absence of wheezing, despite the client's severe distress, indicates that airflow is so critically restricted that insufficient air is moving to produce sounds. This is often referred to as a silent chest and is an emergency, signaling impending respiratory failure. For example, if a client who was previously wheezing profusely suddenly has quiet lungs but remains severely dyspneic, this means they are no longer able to move air effectively. Always be highly concerned when wheezing disappears in a severely distressed asthmatic client, as it signifies worsening obstruction, not improvement. Question 16. A client is diagnosed with obstructive sleep apnea, OSA. Which intervention would the nurse expect to be included in the client's initial management plan? A. Surgical resection of the uvula and soft palate. B. Daily use of prescribed sedatives to promote sleep. C. Consistent use of continuous positive airway pressure, CPAP. D. Encouraging supine sleeping to maintain airway patency. Answer: C. Consistent use of continuous positive airway pressure, CPAP. This question focuses on the standard initial treatment for obstructive sleep apnea, OSA. Continuous positive airway pressure, CPAP, is considered the gold standard and most effective initial treatment for OSA. CPAP delivers a constant stream of air that keeps the airway open during sleep, preventing episodes of apnea and hyponia. Surgical interventions are typically reserved for severe cases where CPAP is not tolerated or effective, and sedatives are contraindicated as they can worsen apnea. For example, a client with OSA would be prescribed a CPAP machine to use nightly to prevent airway collapse. The first-line therapy for obstructive sleep apnea is almost always CPAP, as it effectively maintains an open airway. Question 17. The nurse is caring for a client with a history of recurrent pneumothorax. The client asks about potential future treatments to prevent recurrence. The nurse anticipates discussing which procedure? A. Thoracentesis. B. Bronchoscopy. C. Pleurodesis. D. Thoracotomy with decortication. Answer: C. Pleurodesis. This question tests knowledge of long-term management strategies for recurrent pneumothorax. Thoracentesis is a one-time procedure to remove fluid or air, and bronchoscopy is for diagnosis or removal of foreign bodies. Pleurodesis, however, is a procedure that creates adhesions between the parietal and visceral pleura, effectively obliterating the pleural space to prevent the recurrence of pneumothorax. While a thoracotomy with decortication is a surgical option, pleurodesis is a common and less invasive method to prevent recurrence. For example, a chemical agent like talc might be instilled into the pleural space to induce inflammation and scar tissue formation, sealing the lung to the chest wall. When preventing recurrent pneumothorax, consider procedures that permanently eliminate the pleural space. Question 18. A client has chronic bronchitis. The nurse understands that the primary characteristic of chronic bronchitis is what? A. Destruction of alveolar walls. B. Hyperinflation of the alveoli. C. Chronic productive cough for at least 3 months a year for 2 consecutive years. D. Irreversible airflow limitation due to loss of elastic recoil. Answer: C. Chronic productive cough for at least 3 months a year for 2 consecutive years. This question assesses the defining characteristic of chronic bronchitis. While all options relate to respiratory issues, the classic diagnostic criterion for chronic bronchitis is a persistent, productive cough for at least 3 months of the year for 2 consecutive years. This reflects the chronic inflammation and excessive mucus production in the airways, which are hallmarks of the condition. Destruction of alveolar walls and loss of elastic recoil are more characteristic of emphysema, another form of COPD. For instance, a client who reports coughing up sputum daily for several months each winter, year after year, fits the description of chronic bronchitis. Remember that chronic productive cough is the defining feature when differentiating chronic bronchitis. Question 19. A nurse is educating a client on the proper use of a metered dose inhaler, MDI, with a spacer. Which instruction is most important for maximizing medication delivery? A. Shake the inhaler vigorously for 30 seconds before each puff. B. Exhale completely before activating the inhaler. C. Hold breath for 1 to 2 seconds after inhaling the medication. D. Inhale quickly and forcefully after activating the inhaler. Answer: B. Exhale completely before activating the inhaler. This question focuses on the most critical step for effective medication delivery with an MDI and spacer. Exhaling completely before activating the inhaler creates a larger space in the lungs, allowing for a deeper and more effective inhalation of the medication. This maximizes the amount of medication that reaches the lower airways. While shaking the inhaler and holding the breath are important, ensuring an empty lung capacity prior to inhalation is paramount for optimal drug deposition. For example, teaching a client to take a slow, deep breath after exhaling fully will draw the medication more effectively into the lungs. Always remind clients to fully exhale before taking a puff from their inhaler to maximize lung deposition. Question 20. A client is admitted with a severe asthma attack. The nurse administers albuterol via nebulizer. Which assessment finding indicates the medication is having its intended effect? A. Decreased heart rate. B. Improved oxygen saturation. C. Decreased respiratory rate. D. Increased anxiety. Answer: B. Improved oxygen saturation. This question asks about the therapeutic effect of a bronchodilator in an acute asthma attack. Albuterol is a short-acting beta agonist that opens constricted airways, allowing for better airflow and improved gas exchange. The ultimate goal of improving airflow is to increase oxygen uptake, which will be reflected in an improved oxygen saturation. While heart rate may initially increase due to the medication, and respiratory rate may decrease as breathing becomes easier, the most direct and crucial indicator of improved oxygenation is the pulse oximetry reading. For example, if a client's SpO2 rises from 88% to 94% after nebulizer treatment, it confirms improved oxygenation. Always look for objective evidence of improved oxygenation, such as pulse oximetry, to confirm the effectiveness of bronchodilators. Question 21. A nurse is assessing a client complaining of sudden, sharp chest pain and dyspnea after a vigorous cough. On assessment, the nurse notes tracheal deviation to the unaffected side and absent breath sounds on the affected side. These findings are most consistent with what condition? A. Myocardial infarction. B. Pleural effusion. C. Tension pneumothorax. D. Pulmonary embolism. Answer: C. Tension pneumothorax. This question describes classic signs of a life-threatening respiratory emergency. The combination of sudden chest pain, dyspnea, absent breath sounds on one side, and tracheal deviation to the unaffected side is pathognomonic for a tension pneumothorax. In this condition, air enters the pleural space but cannot escape, causing increasing pressure that collapses the lung and shifts mediastinal structures, including the trachea, away from the affected side. Myocardial infarction presents differently. Pleural effusion typically causes dullness to percussion, and pulmonary embolism does not cause tracheal deviation. For example, if a client experiences these symptoms after a chest injury, a tension pneumothorax should be immediately suspected. Always recognize tracheal deviation as a late, critical sign of tension pneumothorax requiring urgent decompression. Question 22. A client with a long history of heavy smoking reports a persistent cough with hemoptysis and weight loss. The nurse suspects which condition? A. Bronchitis. B. Pneumonia. C. Lung cancer. D. Tuberculosis. Answer: C. Lung cancer. This question focuses on recognizing key warning signs of a serious respiratory malignancy. The combination of a long history of heavy smoking, a major risk factor, a persistent cough, hemoptysis, coughing up blood, and unexplained weight loss are classic red flag symptoms highly suggestive of lung cancer. While other conditions can cause some of these symptoms, this cluster of findings in a smoker strongly points towards malignancy. For example, a client presenting with these specific symptoms would require immediate diagnostic workup including a chest X-ray and CT scan. Always be highly suspicious of lung cancer when these specific symptoms present in a client with a significant smoking history. Question 23. A client is postoperative following a right lower lobectomy. The nurse notes decreased breath sounds in the right lung fields. What is the most appropriate initial nursing action? A. Administer a prescribed opioid analgesic. B. Reposition the client onto the right side. C. Encourage deep breathing and incentive spirometry. D. Prepare for immediate chest tube insertion. Answer: C. Encourage deep breathing and incentive spirometry. This question assesses the immediate postoperative care for a client after lung surgery, specifically focusing on promoting lung expansion. Decreased breath sounds in the operative area are common after a lobectomy due to localized inflammation, fluid, or atelectasis, partial lung collapse. The most appropriate initial action is to encourage deep breathing and incentive spirometry, as these interventions help re-expand the remaining lung tissue and improve gas exchange. While chest tube insertion might be needed for a pneumothorax, it's not the initial response to decreased breath sounds post-lobectomy. For example, teaching the client to hug a pillow when coughing can help manage pain and make deep breaths more tolerable. Prioritize non-invasive measures like deep breathing and incentive spirometry to promote lung re-expansion post-operatively. Question 24. A client with a history of intravenous drug use is admitted with fever, chills, and productive cough. The nurse assesses crackles and egophony in the right lower lobe. These findings are highly suggestive of what condition? A. Acute bronchitis. B. Asthma exacerbation. C. Pneumonia. D. Pulmonary edema. Answer: C. Pneumonia. This question presents a client scenario with specific signs and symptoms pointing to a respiratory infection. Fever, chills, productive cough, and the presence of crackles and egophony, a voice sound change where he sounds like A, are classic clinical indicators of pneumonia, particularly in the lower lobes. Intravenous drug use is also a risk factor for aspiration pneumonia or other severe infections. Acute bronchitis typically presents without egophony, asthma exacerbation causes wheezing, and pulmonary edema is often associated with cardiac history and bilateral crackles. For instance, a client with these symptoms would likely undergo a chest X-ray to confirm the diagnosis of pneumonia. When these specific signs are present, especially with a risk factor like drug use, pneumonia should be a primary suspicion. Question 25. A client diagnosed with hypercapnic respiratory failure requires mechanical ventilation. The nurse anticipates the initial ventilator settings will aim to achieve which primary goal? A. Increase tidal volume to promote lung recruitment. B. Maintain a low positive end expiratory pressure, PEEP. C. Remove excess carbon dioxide and improve oxygenation. D. Deliver high inspiratory pressures to overcome airway resistance. Answer: C. Remove excess carbon dioxide and improve oxygenation. This question tests the primary goal of mechanical ventilation for hypercapnic respiratory failure. Hypercapnic respiratory failure means there's too much carbon dioxide, CO2, in the blood, indicating inadequate ventilation. The main goal of initiating mechanical ventilation in this scenario is to improve alveolar ventilation to remove excess CO2 and, consequently, improve oxygenation by providing respiratory support. While other settings are adjusted, the overarching aim is to correct the gas exchange abnormalities. For example, the ventilator will be set to deliver breaths that help the client blow off more CO2 and bring in more oxygen. The fundamental purpose of mechanical ventilation for hypercapnic failure is to correct the imbalance in blood gases.